Let's take a step back and master the macroanatomy of the nasal cavity to see exactly how these pathways are distributed. When looking at this sagittal view of the nasal septum, we are standing at a critical anatomical crossroads where pure special sensory nerves run right alongside general somatic sensory fibers. If we map these structures out, we can clearly divide them into two distinct neural networks. First, look at the highly concentrated, root-like fan of olfactory nerves clustered at the very superior aspect of the nasal cavity. These delicate, unmyelinated fibers pierce through the roof of the nasal vault to synapse directly into the overlying olfactory bulb, which is why a patient has to actively sniff to pull odor molecules into the highest recesses of the nose to trigger a scent response. Second, spreading across the rest of the mucosa, we see the general somatic sensory branches of the trigeminal nerve, which handle pain, temperature, and touch. Specifically, we can trace the anterior ethmoidal branch of the nasociliary nerve sending its medial nasal branches down the anterior portion of the septum, while the robust nasopalatine nerve sweeps diagonally downwards and forwards across the posterior and inferior regions. Understanding this precise overlapping anatomy is essential for clinical practice because when a patient inhales a sharp, pungent substance like ammonia or menthol, the stinging, cooling, or burning sensation they experience isn't processed by the olfactory nerves at all. It is entirely mediated by these trigeminal branches. Discussion question. If a patient suffers a severe anterior skull base fracture that completely shears the delicate olfactory nerves at the cribriform plate, how would their clinical response to smelling a fresh orange differ from their response to inhaling strong-smelling salts, ammonia? Which neural pathways account for that difference? Let's take a step back and master the Now let's trace how these peripheral signals travel deep into the core of the brain to influence memory, emotion, and autonomic reflexes. When we look at the central connections of the olfactory pathway, we are tracing a highly ancient, interconnected network where olfactory tracts feed directly into the limbic system. Following the pathway from the olfactory bulb, signals travel down the olfactory tract, which splits into the medial olfactory stria and the lateral olfactory stria. The lateral stria delivers information directly to the amygdaloid nucleus and the hippocampal gyrus without passing through a traditional primary thalamic relay first, which explains why odors can trigger instantaneous, raw emotional and memory responses. From these temporal structures, massive downstream circuits are activated. The fornix arches upward to connect the hippocampus directly to the mammillary body, which in turn communicates with the anterior nuclear group of the thalamus via the mammillothalamic tract to complete the classic Papez circuit for memory consolidation. Simultaneously, This entire system interfaces with the brainstem to drive primitive physiological reflexes. Notice the fibers running through the stria medullaris thalami toward the habenula, as well as paths descending down to the interpeduncular nucleus and the dorsal longitudinal fasciculus. These pathways plug directly into autonomic brainstem centers, including the trigeminal nucleus, the superior and inferior salivatory nuclei, and the dorsal efferent nucleus. This extensive network is the exact reason why the simple scent of delicious food can immediately trigger autonomic reflexes like salivation or gastric motility, while a noxious, foul odor can instantly induce visceral nausea. It is a beautiful demonstration of how a single sensory input bridges the gap between high-level cortical processing and primitive, survival-based responses. Discussion question. Given that the lateral olfactory stria connects directly to the amygdala and hippocampus without a prior thalamic filter, how does this specific neuroanatomy explain why patients with lesions or focal epilepsy in the temporal lobe often experience vivid, complex scent-based auras or hallucinations right before a seizure? To truly master the central architecture of olfaction, let's strip away the anatomical noise and map the pathway as a clear, logical flowchart. When we trace the signal from its absolute origin, everything starts at the olfactory epithelium, where specialized receptors detect airborne molecules. These signals travel up through the delicate olfactory nerves to synapse in the olfactory bulb, which acts as the first major processing station. From there, the signal travels along the olfactory tracts until it reaches a critical anatomical fork in the road located right at the anterior perforated substance, APS. At this junction, the pathway splits cleanly into two primary highways, each serving vastly different neurological functions. The lateral olfactory stria, LOS. This is the main projection trunk for conscious odor perception and emotional processing. It routes signals directly to the structures of the medial temporal lobe, including the uncus, the hippocampal gyrus, the piriform cortex, the entorhinal cortex, and the amygdala. Because these lines plug straight into memory and emotional hubs without stopping at a primary thalamic relay station first, smells have a uniquely immediate power to trigger vivid memories and raw emotional states. The medial olfactory stria, MOS. This highway routes medially toward the subfrontal and interhemispheric structures, sending fibers to the parolfactory area, the subcallosal gyrus, and the cingulate gyrus. This network plays a massive role in modulating behavioral responses, emotional valence, and autonomic reflex connections to smells. Understanding this clear division of labor is incredibly practical for neurolocalization on the wards. It shows us that a single sensory input doesn't just register a smell. It simultaneously writes to our memory centers, alters our emotional state, and primes our autonomic nervous system. Discussion question. Looking at this schematic, the piriform and entorhinal cortices receive direct inputs from the lateral olfactory stria. Clinically, the entorhinal cortex is one of the very first zones to undergo neurodegeneration in Alzheimer's disease. Based on this specific wiring, why does it make perfect anatomical sense that a patient might lose their ability to properly identify or recognize familiar smells long before they show severe memory loss on cognitive testing? Imagine standing right at the biological border where your sense of smell meets your body's built-in air filtration system. In this incredible microscopic view, we are looking at a literal transition zone inside the nasal cavity. The bottom half showcases the olfactory epithelium, which is essentially the command center for your sense of smell. It is packed with a dense, tangled jungle of specialized cilia, like tiny cellular antennas, extending from olfactory receptor neurons to catch floating scent molecules from the air. Meanwhile, the top half transitions into the respiratory epithelium, a region lined with a different style of cilia and microvilli designed to trap dust, humidify the air you breathe, and keep your lungs safe. If you look closely where the arrows point, they are highlighting the exact olfactory knobs, which are the dendritic endings of receptor cells where those smelling antennas sprout right at the frontier of the two tissue types. It's a perfect visual example of how the body seamlessly adapts its cellular architecture, switching from a high-tech chemical sensor to a heavy-duty air filter in the span of just a few micrometers. How do you think the structural differences between these two types of cilia relate to their completely different jobs? Welcome, everyone. Let's take a deep dive into the elegant microcircuitry of the olfactory bulb. When we trace the pathway of olfaction, we are looking at a masterclass in peripheral signal processing and top-down neural modulation. The pathway initiates at the base in the olfactory mucosa, where bipolar olfactory receptor neurons capture peripheral chemical stimuli. Their unmyelinated axons coalesce, passing superiorly through the fenestrations of the osseous cribriform plate to enter the glomerular layer of the olfactory bulb. Here, we encounter the glomerulus, a crucial synaptic hub where thousands of primary afferents converging from neurons expressing the exact same receptor type synapse onto the primary dendrites of second-order projection neurons. This architectural bottleneck dramatically amplifies the signal-to-noise ratio. Modulating this initial input are the periglomerular cells, which provide local feed-forward inhibition to sharpen contrast between competing odorants right at the gateway. As we move superiorly into the external plexiform and mitral cell layers, we encounter our primary projection neurons, the smaller, more superficial tufted cells and the prominent, pyramid-shaped mitral cells. These cells act as the main relays, processing the synchronized glomerular inputs and preparing the signal for long-range transport. However, notice the highly sophisticated regulatory network surrounding them. The deeper granule cell layer hosts GABAergic, axon-less granule cells that engage in reciprocal dendrodendritic synapses with the mitral cells. As indicated by the plus and minus signs, these interneurons provide critical lateral inhibition, effectively acting as a synaptic volume knob to suppress adjacent, weaker signals and dramatically sharpen our sensory resolution. Finally, the processed signals are dispatched along the projection highway of the lateral olfactory tract directly to the anterior olfactory nucleus and primary olfactory cortex. Remarkably, this sensory pathway bypasses a traditional thalamic relay, allowing for immediate processing. At the same time, notice the centrifugal axons descending from higher cortical centers. These provide top-down, state-dependent modulation, allowing context, memory, and even hunger to dynamically alter how sensory input is processed at the very level of the bulb. Consider how a physical injury to the cribriform plate, such as from a traumatic brain injury, might disrupt this delicate architecture, not just causing a loss of smell, but completely severing this direct, unrelayed cortical connection. How do you think this immediate, direct pathway to the cortex explains why smells can trigger such sudden, vivid emotional memories compared to your other senses? Let's pivot from the microscopic anatomy directly to a highly practical, gold-standard clinical tool we use to evaluate these sensory pathways in our patients: the University of Pennsylvania Smell Identification Test, or UPSIT. When a patient presents with olfactory dysfunction, we need an objective, standardized way to quantify the deficit rather than just relying on vague, subjective self-reporting. This test is brilliantly designed for clinical efficiency, consisting of 4 specialized booklets that contain a total of 40 microencapsulated, scratch and sniff, odorants. In practice, the patient uses a pencil tip to rupture these microcapsules, releasing the scent, and is then met with a multiple-choice question offering 4 possible identities for that smell. Because this is a forced choice paradigm, the patient must select an answer even if they claim they perceive absolutely nothing. Their responses are logged on a matrix at the back of each booklet and quickly assessed using a simple scoring key. This structured design allows us to clearly differentiate between true normal smelling ability, normosmia, various degrees of partial loss, microsmia, and total loss, anosmia. Furthermore, because of that forced choice format, this test has a built-in superpower. It acts as an integrated safeguard against malingering or faking. If a patient is completely fabricating an inability to smell, perhaps for legal or insurance claims, they will statistically try to get every answer wrong. However, by pure random guessing among 4 choices, a truly anosmic patient should still score around 25%. If a patient scores significantly below chance, they are actively recognizing the smell and choosing the wrong answer on purpose, providing us with invaluable diagnostic clarity. Thinking about how tightly connected the olfactory system is to our brain's memory and emotional centers, why do you think a standardized tool like this is becoming a crucial screening test for the early detection of neurodegenerative conditions like Parkinson's or Alzheimer's disease long before motor symptoms even appear? Now let's look at how our smelling ability changes across a normal human lifespan, and how biological sex influences this trajectory. If we look at how scores on the standard smell identification test change across different age groups, from early childhood all the way into a person's late 80s, 3 fascinating clinical trends stand out. First, notice how the scores start a bit lower in early childhood and steadily climb. Our sense of smell actually improves and reaches its zenith during early adulthood, specifically between the ages of 20 and 49, where individuals consistently score at their highest levels. However, once we cross into the 50s, a visible, progressive downturn in olfactory performance begins. This decline accelerates sharply after age 65 and drops off steeply in the 80 to 89 age bracket. This normal, age-related loss of smell is known clinically as presbyosmia, and it is caused by a combination of cumulative environmental wear and tear, a slowdown in the cellular regeneration of olfactory receptor neurons, and structural changes in the brain itself. But here is where it gets really interesting. If we compare the data lines between sexes, a clear gap emerges showing that women consistently outperform men at every single stage of life. Even as both sexes experience that steep physiological decline in their twilight years, the female cohort maintains a higher median score than their male counterparts across the board. Understanding these baseline norms is incredibly important in a clinic. Before we suspect a neurodegenerative condition or a major neurological lesion in an older patient who performs poorly on an evaluation, we must first account for their age and sex to see if their score actually falls outside the expected physiological baseline for their demographic. Discussion question. Given that women identify odorants better than men at all stages of life, what biological, hormonal, or structural brain factors do you think drive this consistent female advantage in olfactory processing? Now that we have looked at how we identify what a smell is, let's talk about a completely different clinical dimension: measuring a patient's sensory threshold. While identification tests tell us if the brain can correctly label an odor, threshold testing tells us the absolute minimum concentration of a chemical the peripheral receptors can actually detect. A highly precise tool designed exactly for this purpose is the snap and sniff threshold test. This kit utilizes a matrix of 20 specialized presentation wands. To establish a reliable baseline and make sure the patient isn't just guessing, 5 of these wands act as negative controls containing no odor at all. The remaining 15 wands contain a standard testing odorant, typically phenyl ethyl alcohol, which has a pleasant, rose-like scent. These odor-bearing wands are precisely diluted in half-log steps, ranging from a strong, highly concentrated 10 carat -2 dilution down to an incredibly faint 10 carat -9 molecular whisper. What makes this tool a favorite in clinical practice is its clever engineering and hygiene control. When the examiner pushes the black ring forward with their thumb, the odorized tip snaps out to be presented just beneath the patient's nostrils. Releasing the ring instantly retracts the tip back into its protective housing. This design ensures that it is virtually impossible for the patient's nose to physically touch the odor source, which completely eliminates cross-contamination and stimulus carryover. It also keeps the surrounding room air clean, preventing lingering scents from skewing the next trial. By presenting these wands in a controlled sequence, we can map the exact boundary where the patient's olfactory neurons reliably fire. Consider the diagnostic value of combining these 2 testing methods. What clinical conclusions might you draw if a patient has a perfectly normal sensory threshold on this wand test, but performs terribly on a multiple-choice scratch and sniff identification test? Where do you think the neurological breakdown is happening? Alright, team, Let's tie everything we've learned about olfactory anatomy and clinical testing together by looking at the bigger diagnostic picture. When a patient walks into your clinic complaining of a diminished sense of smell, it is incredibly easy to shrug it off as simple allergies or a lingering upper respiratory infection. But as you can see from this extensive clinical list, olfactory dysfunction is an incredibly sensitive, and often overlooked, sentinel marker for a massive spectrum of systemic, psychiatric, and neurological conditions. To make sense of this data, we can categorize these disorders based on exactly where the underlying pathology strikes along the pathway. Structural and peripheral barriers. This includes local culprits like rhinosinusitis, nasal polyposis, adenoid hypertrophy, or direct toxic chemical and tobacco exposure that physically damages the olfactory mucosa. Central and neurodegenerative pathologies. This is where olfaction becomes a critical early warning system. Neurodegenerative giants like Alzheimer's disease, Parkinson's disease, Huntington's disease, and frontotemporal lobe degeneration are famously tied to early olfactory decline. In fact, hyposmia can precede motor or cognitive symptoms in Parkinson's and Alzheimer's by years because the pathology often hits the olfactory bulb long before it spreads deeper into the brain. Psychiatric and neurodevelopmental conditions. We see marked alterations in olfactory processing among patients with schizophrenia, major depression, panic disorder, and autism spectrum disorders, reminding us how deeply interconnected the olfactory tract is with the limbic system and emotional regulation. Systemic, metabolic, and genetic anomalies. Conditions ranging from chronic renal failure and diabetes to genetic syndromes like Kalman syndrome, where olfactory bulbs fail to develop altogether, and vitamin B12 deficiency, all present with measurable olfactory deficits. When you look at a spectrum this comprehensive, it becomes clear that olfactory testing isn't just a niche sensory evaluation. It is a window into global neurological and systemic health. Discussion question. Why do you think a localized neurodegenerative process like Parkinson's disease compromises olfaction so severely, while a demyelinating disease like multiple sclerosis can also cause fluctuating olfactory deficits? To wrap up our deep dive into the olfactory system, let's focus on the clinical realities of encountering a patient with a persistent loss of smell. In clinical practice, you cannot simply assume a patient's anosmia or hyposmia is due to a routine upper respiratory tract infection. If we look at the diverse causes of long-term olfactory deficits, we can organize our clinical approach by dividing these pathologies into a few highly logical categories based on where and how the damage occurs. First, we must always rule out intracranial mass lesions and structural obstructions that physically compress the pathway or block airflow. An olfactory groove meningioma, a frontal lobe glioma, or a paracellar tumor can silently compress the olfactory tract running along the base of the skull, making persistent smell loss an early, localized warning sign of a growing neurosurgical emergency. Similarly, local tissue changes like a deviated nasal septum, nasal polyps, chronic sinusitis, or intranasal tumors like epidermoid carcinoma physically prevent odorants from ever reaching the epithelium in the first place. Second, we look at neurodegenerative, congenital, and systemic medical conditions. Familiar neurological giants like Alzheimer's disease, Parkinson's disease, and multiple sclerosis prominently feature early olfactory decline. On the congenital side, conditions like Kalman syndrome link hereditary hypogonadism directly with a complete failure of olfactory development, while conditions like rhinencephaly or olfactory dysgenesis highlight structural developmental failures. Furthermore, metabolic and nutritional status play a massive role. Systemic deficiencies in zinc, copper, or vital vitamins like B6, B12, and vitamin A can completely derail the chemical signaling or cellular regeneration of these sensory neurons. Finally, as future clinicians, you must meticulously review your patient's toxicological, pharmacological, and environmental exposures. Direct epithelial damage can be caused by smoking, cocaine use, chemical burns, or radiation therapy. Additionally, an incredibly wide variety of common medications and substances can cause an unprompted, persistent drop in olfactory function. This includes therapeutic agents like chemotherapeutic drugs, specific antibiotics, antihistamines, propylthiouracil, amphetamines, and even medications used to treat neurological conditions themselves, such as levodopa. When a patient presents with a persistent loss of smell, your job is to systematically work through these categories: structural, neurosystemic, and chemical, to pinpoint the true root of the problem. Discussion question. Imagine a 45-year-old patient presents to your clinic with a 3-month history of progressive, one-sided loss of smell, accompanied by mild, worsening headaches. Given the causes we just discussed, which specific structural intracranial pathologies must be at the very top of your differential diagnosis, and how would you definitively rule them out? Now, let's tie our understanding of clinical testing directly to differential diagnosis in neurology by looking at how different neurodegenerative conditions strike the olfactory system. If we organize various neurological diseases on a scale from completely normal smelling ability, O, to marked, profound damage, ++++, we discover a highly valuable diagnostic roadmap. Notice that the absolute most severe, profound smell loss, ++++, occurs in conditions like idiopathic Parkinson's disease, Alzheimer's disease, dementia with Lewy bodies, and idiopathic REM sleep behavior disorder. This happens because their underlying pathologies, such as alpha-synuclein aggregates or beta-amyloid plaques, aggressively invade the olfactory bulb and anterior olfactory nucleus at the very earliest stages of the disease process. As we move down the scale, we see moderate to mild damage, ++++, in conditions like Huntington's disease, multiple system atrophy, and certain genetic subtypes of Parkinson's. But here is the critical clinical takeaway that you will use constantly on the wards. Look at the disorders paired with a 0, normal. Conditions like essential tremor, vascular Parkinsonism, progressive supranuclear palsy, PSP, and even certain genetic mutations like PARK2 show completely normal olfactory function. This means if a patient walks into your clinic presenting with Parkinsonian tremors and rigidity, a simple, objective smell test can help you clear up a muddy differential. If they have severe smell loss, it points strongly toward idiopathic Parkinson's. If their smell is perfectly intact, it guides your diagnosis away from typical Parkinson's and toward vascular Parkinsonism or PSP. It is a stunning example of how assessing a basic cranial nerve pathway can reveal the underlying molecular pathology of the brain. Discussion question. Given that idiopathic Parkinson's disease shows marked olfactory damage, ++++, while vascular Parkinsonism and progressive supranuclear palsy show normal olfactory function, 0, what does this tell us about how the anatomical site of initial tissue damage differs between these clinically similar movement disorders?